You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 12, 2024. Our topic is the evaluation of recurrent infections for inborn errors of immunity. This is presented by Dr. Nikita Raje. She is an associate professor of internal medicine and pediatrics and is the chief in the section of allergy immunology at Children's Mercy Hospital.
All right, let's get started. Thank you for that introduction, and I'll be talking about inborn errors of immunity. Our focus today is how to evaluate the recurrent infections when we are thinking of inborn errors of immunity. Let's see how that. All right, so here are some of my disclosures, really nothing pertaining to the talk today. The learning objectives for today are to recognize various causes of recurrent infections, to classify primary immunodeficiencies or inborn errors of immunity, and to outline the tests for various types of IEIs. Here's the outline, really going over why we work up patients for recurrent infections, when do we get worried about these, what kind of differential should we be having, and how to go about evaluating these infections. So the first and foremost question is, why is it important to work up patients with recurrent infections? Could we not just go ahead and treat the infections as they occur? And to really, understand if there is an underlying cause leading to some of these infections can help reduce the morbidity and mortality, improve quality of life. Also, it helps save some resources if we are expecting and can prevent some of these infections. And the underlying cause can have implications other than recurrent infections. So being able to modify or look for some of those, modify the management and look for some of those non-infectious concerns and complications. What kind of infection should we be worried about? So yes, recurrent infections can be an issue, but recurrent is a very subjective word. It can be 4 sinus infections or 2 pneumonias, or it just depends on what infection we are talking about. And so yes, recurrent infections can be a concern, but just kind of keeping in mind some of the features of these infections when we should be worried about these. That includes if there is a severe life-threatening infection, such as say a rhinoenterovirus leads to sepsis. Those are patients where a simple virus shouldn't be causing septic shock, should not be in ICU, but then some of our patients do show up in these kind of conditions where a life-threatening infection can draw attention to the infection. If the infection is in unusual site, so even a single infection in the liver abscess, or meningitis can draw our attention to those not so common infections where we should be worried about some underlying cause. Infections that are resistant to optimal therapy. So if you need IV antibiotics for some simple infections just because they are not cleared with the typical therapy that you would usually employ, should kind of draw your attention again. And one of the examples would be if you're using IV antibiotics for say sinus infection. And then opportunistic infections, we all are aware if there is an opportunistic infection going on, we would always think of an inborn error of immunity. So now that we think that would be a problem, what kind of diseases should we be thinking about? So again, few things that we would, this is the talk on primary immunodeficiencies or IEIs, so we would definitely think about that. But keep in mind that those are rare disorders, and more common things such as secondary immunodeficiency should come to our mind, and even more common than that would be other causes. So let's look at some of these causes or diseases that can predispose patients to recurrent infections. So some of these other causes can be related to either the host or the environment or the pathogen itself. So simple things like, so in general, if you think of the host features like age, extremes of age, some genetic conditions, anatomy, comorbidities. Some of these patients can be predisposed to recurrent infections, or to the environmental factors such as smoke exposure, or patient going to daycare, or just the weather related viral seasons. And then host factors depend on various types of organisms that we come across. So here's a list of things that can affect immunity or predisposition to infections, such as a daycare going 2-year-old, 3-year-old is more prone to having infections as they get exposed to various bugs as they go there. School going siblings, that's a common phenomenon where we see patients who are younger, they are not going to daycare, but their siblings are in school and they are bringing in viruses. The school going siblings are already immune and don't get sick, but the younger sibling might get those infections and be symptomatic. Smoke exposure, having reflux or aspiration, patients with allergic rhinitis or nasal polyps. These patients can get recurrent infections that can look like having and mimic IEI, but that might just be secondary to the underlying polyps or allergies. Similarly, patients with asthma and bronchiectasis may present with features that either look like pneumonia or getting frequent pneumonia and may mimic IEI. Atopic dermatitis can predispose patients to having recurrent skin infections, and then some anatomic issues like primary ciliary dyskinesia or cystic fibrosis can also lead to recurrent infections. So keeping these causes in mind, and then thinking of maybe the immune system can be affected, but it's not the underlying issue is not in the immune system. So I would point out that that's the major difference between the secondary immunodeficiency or primary immunodeficiency, that if it's primary, the defect itself lies in the immune system, versus if it's a secondary immunodeficiency, the defect lies somewhere else and it affects the immune system. So some of the common things that can affect the immune system are infections such as HIV, EBV, CMV. These viruses can suppress the immune system. Nutritional issues like zinc deficiency, protein calorie malnutrition can lead to suppression of immune system. We are all aware of the iatrogenic causes of immune suppression like corticosteroids, chemotherapeutic agents, some biological agents, radiation therapy. But even simple medications like anti-epileptics can affect the immune system. It can lead to low immunoglobulin levels, and so making sure that you are looking at the medication list when you are evaluating patients with recurrent infections. Patients with asplenia, this could be congenital or it could be due to trauma, and that can predispose these patients to specific infections. We talked about extremes of age where the immune system is not well as mature with prematurity or infancy, versus the immune system immunity starts waning with old age. Protein losing conditions such as nephropathy or enteropathy, where the immunoglobulins are also lost in the process of protein loss. And then disorders such as cancer, autoimmunity can also either directly cause immunosuppression, or the treatment can lead to immunosuppression. But the topic of our talk today is IEIs, inborn errors of immunity, which is the newer name for primary immunodeficiencies. And as we know, these are zebras, but we are in the field where we should be thinking of zebras more often than not. So let's get started on talking about these IEIs. But the first thing we want to just kind of summarize is what you guys are very well aware of, just the immune system in general. So we know that the cells of the immune system come from the stem cell. They have a choice of being either a lymphoid cell or myeloid cell, and can become variety of different cells as noted here. And then we know that the immunity comes in two forms, innate immunity and adaptive immunity. Innate immunity is hardwired and present when a child is born. It doesn't adapt or doesn't change over time. And there are physical barriers, cellular components, or proteins such as complements or toll-like receptors that provide that innate innate immunity that can be effective within hours of the infection occurring, versus the adaptive immunity that's provided by T cells and B cells takes times to develop. So over a period of days rather than hours that it's available. Also, it's adaptable. So it's more specific, it's more sophisticated, but takes time to develop. So thinking about that, just kind of going over how to think about how that immune response occurs. Think about a child walking barefoot in the yard and gets a splinter in the toe. That splinter is sitting on the ground for a long time, might have viruses, bacteria, fungi, any kind of organisms that have now broken the physical barrier. So now they are inside the tissue. When that happens, there are these sentinel cells that are sitting in the tissue. They are there already present, part of the innate immune system, such as macrophages, mast cells, dendritic cells. They take that information of what kind of infection is it. Is it viral or bacterial? Is it in the toe? Is it in the brain? Is it in the liver? And takes that information and starts fighting that infection. So these cells start releasing cytokines that go to the circulation and give the message saying they need help. And the first responders, such as neutrophils, come to the site of infection to help fight that infection. In the meantime, the dendritic cells get into the lymphatic system and go to the lymph nodes with the information and provide that to the cells of the adaptive immune system, mainly the T cells, and the message reaches the B cells as well. The B cells start making antibodies, immunoglobulins M, G, and based on the type of infection can switch to G, A, or E. Whereas the T cells start making helper T cells or cytotoxic T cells based on the type of infection that they have come across. So that's how the innate immune system and the adaptive immune system together provide the immune response. So keeping this in mind, we want to kind of go over when to think about what kind of immune issue. So why are we worried about these IEIs? So we know that there are multiple types of inborn errors of immunity, and the classification for IEIs is provided by International Union of Immunological Societies, or IUIS. This society comes together and updates this classification every a couple of years. The last classification came in 2022. This picture is actually a little older, but it gives you an idea of how the number of immunodeficiencies that we know of have gone up over time. And in 2022, the classification had 485 genes that can cause IEIs. That number is old, and we are above 500 at this point. The new classification should be coming out end of this year or early next year. So we'll have even more number of IEIs to think about. Regardless, the 10 categories of IEIs are mentioned here, and sometimes you will see that the IEIs that you are looking for can switch the category based on the knowledge at that time and the predominance of the part of the immune system it affects. But regardless, overall, the classification goes over this part of the immune system that it affects, whether it's combined immunodeficiencies or just the B cells or antibodies that are affected, versus if there is a phagocytic defect or complement defect. So we'll go over some of these categories. We're likely not going to touch on the autoinflammatory disorders or bone marrow failure disorders or phenocopies. Some of these disorders don't really present with infections as their main feature, which is the topic for today. But we'll touch upon the rest of the categories. So here's just talking about the same feature, same thing, IUIS classification. This is the last classification that came out 2022, and it shows how, there are multiple inborn errors of immunity that were discovered between 2019, which was the last update, and 2022. So there were 55 new IEIs that we know of with this update. So how common are the IEIs? We know that, these are all rare disorders. In 2007, researchers did a population survey, which means they called up general people and asked if they have an immune defect. 1 in 1,200 replied that they have an immune defect. That was a very rough estimate, but that was the best we had at that time. Now we know that the prevalence or incidence differs based on the type of immunodeficiency. So it could be as common as 1 in 300 or 400 for something as common as selective IgA deficiency, or could be rare as in chronic granulomatous disease, 1 in 250,000. But we know that newer defects, we really don't have the exact incidence determined yet. All right, so let's talk about the evaluation. So how do we evaluate recurrent infections? And as the slide suggests, really the most important part of the evaluation is history. But in practice, everyone comes in with, for our practice, we have so many patients who come in saying they have recurrent infections. So how do we know when to be worried about it? And so we have this 10 warning signs that were these were explained by this Jeffrey Modell Foundation. It is a foundation that does a lot of advocacy around immunodeficiencies, and they came up with these 10 warning signs so that providers, general physicians know when to think about immunodeficiency and send those patients to us. So whether that's recurrent infections in form of 4 or more ear infections or 2 or more serious sinus infections, pneumonias, whether there is presence of family history, opportunistic infections, infections that need IV antibiotics, or deep-seated infections, all of those can be warning signs. The type of infection also matters. If you are seeing specific type of infections that go along with a particular type of IEI, we should be aware of that. For example, if there are catalase positive organisms like Serratia, Burkholderia cepacia, Staphylococcus, you might want to think about chronic granulomatous disease. HSV encephalitis can be caused by defects in TLR3 pathway. Again, this is just a list of various infections. It's not a comprehensive list. There is a very long list of infections of a particular type and the IEIs that can be associated with it. But these are some of the examples. For example, if you see enteroviral encephalitis, you might be thinking of XLA. EBV is associated with immunodeficiencies. So EBV is kind of interesting because it can suppress the immune system in a secondary way, but it can also be associated with these IEIs that can lead to predispose these patients to having recurrent EBV infections. So X-linked lymphoproliferation, type 1, type 2, CD27, ITK, MACT1. MACT1 is also called X-Men syndrome, PI3 kinase delta. In terms of HPV infections, these can be common with DOCK8 deficiency. EVER1 and EVER2 is just HPV infections, and they may not have other kind of infections or other issues. GATA2, WHIM syndrome, these can be associated with warts. Chronic mucocutaneous candidiasis is associated with STAT1 gain of function, IL-17 receptor defects, APICID. So again, not a comprehensive list, but there are a lot many more in this CC category, but just some of the ones that you want to think about. Invasive fungal infection, if you see one, think about CARD9 defect. There aren't many IEIs that are yet known, but I'm sure they are out there that we are not aware of yet. And then SARS-CoV-2 was a lesson in immunology, really real life lesson for all of us. And we realized that there were several IEIs that predisposed some of these patients to SARS-CoV-2. Life-threatening infections resulted from TLR3 defects. Some of the defects mentioned here are in that pathway, or interferon alpha receptor defects that have been associated with SARS-CoV-2. But also kind of keep in mind that when you think of these recurrent infections, you want to think about the comorbidities. So if there are other features that these patients present with, such as infections with atopy or autoimmunity, say granulomas or lymphoproliferation, or even malignancies, you want to think about immunodeficiency, because a combination of these means that there is some kind of immune dysregulation going on. So what kind of comorbidities are we thinking about? So for example, there can be autoimmune features for some of the IEIs. Common variable immunodeficiencies can be associated with GLILD or granulomatous lung disease. ALPS is associated with hepatosplenomegaly and lymphadenopathy. 22q deletion is associated with autoimmune thrombocytopenia being one of the most common, but there can be other cytopenias like hemolytic anemia as well. Same with hyper IgM syndrome that can be associated with autoimmune hemolytic anemia. Talking along the terms of lymphoproliferation, XLP is one of the examples that is associated with lymphoproliferation, and some of these patients can have EBV infections as well. Malignancies, different types of malignancies have been associated with particular IEIs, selective IgA deficiency, CVID, XLP, and the list goes on. Wiskott-Aldrich, atopy. Atopy is present in some of the IEIs that are very typical, STAT3, loss of function, DOC8, which are called hyper IgE syndrome, Wiskott-Aldrich syndrome, that's associated with eczematous rash, as well as other atopic issues. Just kind of keeping in mind, I did mention hyper IgE syndrome, but the IUIS classification really took DOC8 out of that classification and put it in combined immunodeficiency, so another category, just because it behaves more like combined immunodeficiency. But yes, the IgE is high in those patients as well. All right, moving along and talking about physical exam. Does it help us in the evaluation of immune system? So we have all our history. If we are evaluating a patient, how would physical exam help us? And sometimes it does, and sometimes it doesn't. There might be dysmorphic features for some of the syndromes. Some of the patients like SCID will have failure to thrive. Some may have hepatosplenomegaly or lymphadenopathy with lymphoproliferation. Rashes might be a clue, or there might be features of particular syndromes such as hyper IgE syndrome or cleft lip palate in 22q deletion. And then sometimes absence of a sign is a sign. So if there is absence of tonsils in a young child or lymph nodes that are absent, that can be a sign of, say, X-linked AGAM, or for lymph nodes, it might be a sign of SCID, but it's harder to see what you don't see, and kind of keeping in mind that when you're evaluating for some of these disorders, that these things may come in handy. This is another example of physical exam coming in handy. Ectodermal dysplasia is present in some of the patients with IEIs where there can be, as the name suggests, ectodermal dysplasia, so conical teeth, sparse hair, or nails that are deformed. All of those are features of ectodermal dysplasia. All right, so we have our history and physical exam. Now we move on to the lab evaluation, and kind of keeping what we are thinking of in our differential based on history and physical. We can get our testing for lab testing done. And this is just a list of tests that we would be coming across or we would be ordering. First, when we are thinking of humoral immune defects, the screening tests that we typically use are immunoglobulin levels, getting antibody titers for vaccines, and then maybe giving them boosters of vaccines and rechecking the vaccine titers. More testing, advanced testing involves flow cytometry for B cells, cells, checking B cell subsets like naive and memory B cells or specific markers of immaturity, looking for functional flow cytometry such as in X-linked A-gamma globulinemia. And then genetic testing has become more and more accessible and favorable just because of the complexity of the various immunodeficiencies that we now know of. And then this picture here just shows how the flow cytometry is done. I believe you guys will have or have already had a talk just on flow cytometry, so not going into details of that. Cellular immune function, the screening tests are the basic tests, cell counts. Look at the CBC, 70% of your cell counts, lymphocytes are T cells. So if the T cells are defective or absent, your ALC would definitely be low. So that's a good screening test. Flow cytometry, looking for markers for T cells, NK cells, subsets of T cells. Newborn screening for severe combined immunodeficiency that is now available for all 50 states. So those are the screening tests. The older test for function of T cells was delayed type hypersensitivity testing. So pretty much doing a TB test, instead of using the TB antigen, we would use the Candida antigen and look for a reaction 48 hours later. And really, we don't use it anymore. When I say that I have used it in my practice, it makes me wonder how long I have been in here working on this. But this is a fast-moving field. There are various advanced tests that we use, which now we use pretty commonly, including proliferative response to mitogen and antigens to look for lymphocyte proliferation. Advanced flow cytometry for some of the disorders, looking for particular markers, and then genetic testing. And then in genetic testing also involves looking for particular copy number variants, such as 22q deletion syndrome or 10p deletion that looks like the 22q deletion syndrome as well. Phagocytic disorders, when you test for these, you are again looking for your basic cell counts, looking for absolute neutrophil count, and then other than that, particular type of tests that you order for particular disorders, such as chronic granulomatous disease. Your testing involves dihydrorhodamine assay or oxidative burst test, just different names for the same test, where it looks for the fluorescence, and this chart here shows how the fluorescence helps in looks like in what it looks like in histogram, where there is shift on the graph if there is good fluorescence, which means that there is oxidative capacity, and that's a normal person's oxidative burst. Versus if someone has CGD, they may not have that shift in the graph just because of absence of fluorescence, and that's because the dihydrorhodamine that is tagged with neutrophils, if it's oxidized to rhodamine is fluorescent, and that's the fluorescence that we are looking on this chart here. Flow cytometry can be done for markers of leukocytes called leukocyte adhesion molecules, and if they are defective, then you can the flow cytometry can show that defect. Genetic testing again is a good option. Looking for complement defects, the screening tests involve CH50, which looks for the classical pathway defects, AH50 for alternative pathway screening, and then MBL is for mannose binding lectin pathway screening. We typically don't use mannose binding lectin pathway screening just because it's a controversial immunodeficiency. A lot of people are walking around with low MBL levels and doing completely fine, so really don't need to look for that. This is just a complete list that I wanted to mention. And then depending on CH50 and AH50 levels, you could order individual complement components to look for a particular complement defect. Innate immune defects, there are tests for toll-like receptor pathways to look for the function of that. For natural killer cells, there are cytotoxicity assays. These are different types. Functional assays that look for the cytotoxicity. However, one of the more more recently used marker is CD107A. That is a good marker of cytotoxicity. Flow cytometry is also can also be used for NK cell markers, and then genetic testing is available. In general, when you're thinking of immunodeficiencies, always think of secondary immunodeficiencies. And so just kind of thinking of various viral studies, inflammatory markers, use peripheral smear or biopsy of affected tissue. All of those can come in really handy when you're getting the workup for some complicated immunodeficiencies. And then now I wanted to talk about genetic testing. I mentioned genetic testing in several slides, and that's more and more easily accessible, as I mentioned, and has higher chance of finding the underlying cause because some of the IEIs have various phenotypes for the same gene defect. On the other hand, various genes can give a similar phenotype, and so the evaluation is getting more and more complicated, and genetic testing definitely helps. So why get genetic testing? Here's your answer. This is from the IUIS classification, and the number of immunodeficiencies or the genes that cause immunodeficiencies has been growing rapidly. So really basic. Think about a cell. What's the genetic material? It all comes from it's all in the nucleus. It is all in a compact form on the chromosomes in the DNA. Right. That DNA is in two forms: heterochromatin and euchromatin, based on various factors that form of euchromatin or heterochromatin means that some genes are expressed and some genes are not expressed or available for expression, depending on the form of DNA or chromatin at that point. But overall, the genetic material is in the DNA, and that DNA, as we know, is transcribed to RNA and then translated to proteins. So let's look at all the genetic testing that's available to us. It's a library of genetic tests. And why do I say that? It's overall, you have several tests and you have to choose which one you're going to order. And getting one doesn't mean that you're looking at the whole picture because there are various types of testing that look for various features of the genes. So you have to be aware of those shortcomings. When you are ordering a full exome, that's still 1% of your overall genome. And the reason why we end up ordering exome sometimes is still most of the IERs or most of the disease-causing genes are in that 1% of the exome. What does exome mean? Exome means that the DNA is made up of introns and exons. Exons get transcribed and translated to make proteins, versus the introns are non-coding genes, but they are really important for regulation of these genes. So they still play a part, and there could be defects in the intronic genes that can lead to disorders. All right, so types of genetic testing, karyotype is one of them, right? So karyotype looks for major issues, say trisomies. Then there is microarray that looks for copy number variants, such as, say, if you're thinking of 22q deletion syndrome, you might want to order a microarray rather than a karyotype. Single gene sequencing, when do you get just this one gene? One of the examples is if you have a patient that fits the picture of A-gamma globulinemia, it's a boy, you're thinking of X-linked AGAM. Rather than ordering multiple gene testing, you can order for the BTK gene that is the culprit for XLA. If you have a disorder such as SCID, you may want to just go ahead and start with a gene panel for all the known SCID-causing genes, rather than ordering a bigger test such as exome sequencing. But when you see patients with multiple system systems being involved, you might want to get exome sequencing, because these are the patients where your particular gene panel for immunodeficiencies or another disorder may not do justice, and you may not find the answer you're looking for. One of the examples is if you are seeing a patient with very early onset IBD, these are the patients where an immune defect is known, or there is a higher chance of having an immune defect that is underlying the IBD. And so some of these patients they have GI issues going on, they have immune issues going on. You may want to get exome sequencing rather than ordering a panel. And then genome sequencing. It's available clinically. There are patients who get genome sequencing. However, this is more for undiagnosed IEIs where you don't find an answer from one of the above. And then RNA sequencing. It's an advanced test where you got your genetic testing, so your gene sequencing, whichever type you got, you don't have the answer, or you have a partial answer. You want to look into it further. RNA sequencing is available. It's not used clinically at most places, but it is available, and it's getting into that clinical arena at this point. So these are the different tests that you are ordering. But what you have to be aware of, that it's like a library. So if you go to a library and stand in front of the bookshelf, and you were told to make sure that everything is in order, that being in order can mean a lot of different things. If you are asked to just check whether the books have everything they need, or if the library has all the books in order, it could mean that you are looking for a missing book or a missing page, or is someone asking you to check each word to look for and go through spell check. And so if you are looking for a missing book, that's like ordering a karyotype. You are looking for a missing chromosome or an extra chromosome. That's what we are talking about when we get a karyotype, such as trisomy or monosomy, things like that. Versus if you were asked to look for a missing page, looking at a karyotype may not give you the answer. What I mean is, if you're looking for a small deletion, looking at the number of books in the library may not give you the information of whether there is a missing page, because you have a far away view. You have to pick up the book and look at each page to see if there is something missing. Same thing happens with the microarray. If you are looking for a small deletion or duplication, you really have to go through each gene and look for a missing piece of the chromosome. So that's that can give you an answer, such as 22q deletion syndrome and things like that, or a duplication for that matter. Now, when you are asked to look for whether the words are in order, or whether there is something missing in a spelling, words, things like that, you are looking at sequencing, which means you have to go through each page and each word to see if the words are spelled right. And that's what we are doing with gene sequencing, is the genetic code that's written in with nucleotides, right? And they have those nucleotide bases have letters attached to it. So you are really looking at the code or the spelling, whether it's spelled right or not, if there is a missing letter, if there is an added letter, or if they are out of sequence. And that's your sequencing. You're going through one gene and looking at the code to see if there is something missing or not in the right order. Exome sequencing means we are doing that spell check for all the protein coding genes, and genome sequencing means that we are doing that spell check for the whole genome. So that's the background for the genetic testing. So when you are looking at the exome sequencing and you've got all the genes, or the genome sequencing, you've got all the information, can you be missing something? And so you have to keep that in mind, that even though you ordered like an exome sequencing, there could be something that you could have missed because you did not look for a missing piece, right? You were looking for the spell check and making sure that each word has the letters that it needs. But if a word is missing or a page is missing, you may not have the view that you need to look for that. So you could be missing a deletion or duplication because the exome did not look for it. So ordering more testing does not mean that you will have the answer you're looking for. All right, so with that background, we want to kind of go ahead and start talking about some of the cases in the last few minutes. So what kind of IAIs are we going to be thinking of? Really, we are looking for a needle in a haystack, and the same things that we talked about. We're going to look for various type of immunodeficiencies, but let's look at some of these cases. And this is interactive, so please feel free to unmute yourself and shout out the answers. A 6-year-old boy was noted to have recurrent sinus infections, including one that needed IV antibiotics, 3 episodes of pneumonia, frequent ear infections despite ear tubes, had gastroenteritis that took several weeks to resolve, but he has no chronic medical conditions. What do you want to know in the history? What labs would you want to order? Any IIs that you can think of that would fit the picture? Anyone? At the liberty to call upon the especially second years, but my Children's Mercy Fellows for sure. So feel free to jump in and anything that comes to your mind. Or anyone for that matter.
Recurrent, like pneumonia, ear infections. Sometimes you think about like CVID comes to mind.
Okay, yeah.
If he responded to antibiotics.
I'm sorry, what was the question? I heard antibiotics. Any other comments? All right, we'll go with that. CVID comes to your mind just because these are patients who have sinopulmonary infections. You're thinking of B cells. Some of the things that I would want to ask is, is there a family history of immunodeficiency? That is one of the feature that, in the history that should draw your attention, and there is a higher likelihood of IEI if there is a family history of inborn errors of immunity. And if you're thinking of B cells, you're going to get workup for B cell immunodeficiency. CVID is one of them. So, but as you can see in this response, the innate immune system would still be intact and doing its job. It's only the adaptive immune system that's affected, especially the B cell arm, and the T cells may still be doing their job. And so if there is a defect, are there enough B cells? The questions are there enough B cells? Are there enough antibodies? Or if there are antibodies, are they functional or not? And that can help you define the different types of B cell immunodeficiencies listed here. But regardless of which B cell deficiency it is, they all kind of present similarly with recurrent sinopulmonary infections or GI infections. So let's talk about agamma-globulinemia. Here there are no mature B cells in the circulation. If there are no B cells, we don't expect immunoglobulins, we don't expect response to vaccines or functional antibodies. There are various genes mentioned here, the most common being the X-linked, which is the BTK gene, but there are autosomal recessive, which means girls can present with AGAM and may have one of these defects that can be inherited in an autosomal recessive fashion. That can be mu heavy chain or Ig alpha, beta, lambda phi, blink, and the list goes on. So a lot of genes that are autosomal recessive, but the common one is BTK, which is X-linked for the XLA. Patients present after the maternal immunoglobulin disappear from the circulation at about 3 to 6 months age. These patients present with bacterial infections, which are the hallmark, but can have protozoal infections, viral infections, all of those. Particularly XLA, you may see enteroviral encephalitis. Treatment involves replacement with immunoglobulins. Common variable compared to XLA, these patients will have B cells in their circulation, but they don't make enough antibodies, and so there is poor response to vaccines. Again, a long list of genes that have been named so far. However, that's still not a complete list, and there are several patients who do not have a known gene defect that we know of, but they meet the criteria for CVID. These patients present after 2 years of age. Depending on the type of criteria you're looking at, you may hear 4 years of age or 2 years of age after which you diagnose CVID. These patients present with various bacterial infections, viral infections, protozoal infections. They also have non-infectious issues going on that could be GLILD, malignancies, autoimmunity, and that gives the name common and variable. It's more, the presentation is variable, so apart from infections, they have other issues that can present as well. Treatment depends on their presentation. Immunoglobulin replacement is the mainstay of the infection of the treatment, but depending on the non-infectious issues, they may need immunosuppression or biological medications as well. Moving on, selective IgA deficiency. Here the B cells are normal in number, IgG, M, E are normal except IgA that is low. Because the other immunoglobulins are normal, they can have variable response to vaccines. Some of them can have normal response, some of them not. And so they can be asymptomatic or they may have infections. They can also present with autoimmunity and over time evolve into complete CVID. So CVID is low IgG, either A or M immunoglobulin is also low, and poor response to vaccines. There is no other cause of those findings, and the child is typically about 2 to 4 years of age. That's CVID. If your IgG is normal, but the IgA is less than 7, and the child is more than 4-year age, that's when you diagnose selective IgA deficiency. These patients may need just monitoring. If they are doing okay and not having infections, they may need prophylactic antibiotics. And if their response to vaccines is low, they may need immunoglobulin replacement once in a while. Specific antibody deficiency means their B cells are normal in number, immunoglobulins are normal in number, but the response to vaccines is low. These patients can present just by specific antibody deficiency or as a part of another immunodeficiency. Treatment, again, depends on presentation, just monitoring, giving them vaccine boosters, prophylactic antibiotics, or immunoglobulin replacement. Another condition is transient hypogam of infancy. Here the B cells are normal and response to vaccines is normal. However, transiently the IgG-MA can run low. That happens because the maternal immunoglobulin disappears from the circulation, but the immune system, baby's immune system has not taken up the job and is lagging behind in making those good antibodies. So most of these patients are asymptomatic, but if they do have recurrent infections, they may need similar treatment. All right, second case, 5-month-old is sent in for immune evaluation for recurrent infections, poor growth, has frequent thrush, chronic runny nose, congestion, ear infections. What do you want to know? What labs would you get? Name some IEIs that fit the description.
So I definitely want to know more about other like fungal infections in the history.
Sure. And so fungal infection caught your eye. So that's good because that would kind of make you wonder if it's more than just the B cells that are involved, right? Something to think about. Another thing that now you can always ask about is the newborn screen. What happened? 5-month-old. What was the newborn screen? Was it normal? Not normal. So start thinking about those things. You want, again, always think of family history. Is there a family history of immunodeficiency? And what labs would you get? Again, we talked about several. In favor of time, I'll go ahead and talk about it. But here we would be thinking of T cells. Here again, the innate immune response would be normal, but when the information reaches the lymph nodes, the T cells may not be in order. And because of that, the B cell function can also be affected. So the question is, are there enough T cells, or if they are doing their job, and if they are not, the B cells are affected or not, function of B cells are affected or not. And so severe combined immunodeficiencies other than SCID, as well as immune dysregulation disorders can be part of the presentation. These patients for SCID particularly present early in life with infections of all kinds, bacterial, fungal, opportunistic. They present with rashes or diarrhea. They have failure to thrive. And SCID, as we know, is fatal unless it's diagnosed early and treated promptly. Treatment involves stem cell transplant. We know that there are gene therapy protocols that are present, but that's research based. And for particular types of SCID, enzyme replacement can be used as a bridge. So subtypes of SCID, that depends on the phenotype of SCID, which means whether the T cells are, apart from T cells, if B or NK cells are present or absent. So T minus, B minus, NK minus can be caused by ADA defect. That's where you can use the enzyme replacement. T minus, NK minus is the most common form, which is the common gamma chain defect, which is X-linked. Similar one, which is autosomal recessive, is JAK3 defect. T minus, B minus means that there is a VDJ recombination defect, and all of these are called radiosensitive SCID. RAG1, RAG2 being the most common, Artemis, ligase 4, all of those are part of that T minus, B minus SCID. T minus, if it's just the T cells that are affected, but it still causes SCID. So absent T cells, you're thinking of IL-7 receptor defects, CD45, TCR defects, or it could be something like, instead of SCID, it could be congenital athymia, such as in 22q deletion or CHARGE syndrome. And then sometimes some of the defects can vary in their phenotype. Newborn screening, as I mentioned, now it's present in all 50 states. You're looking for the process is to get a heel prick and the dried blood spots. There's a punched out part of that dried blood spot that's used for PCR, running PCR for something called TREX, or T cell receptor excision circle. What does that mean? That means that the T cell receptor, when it's formed, this is the DNA in the T cell. It's trying to make a T cell receptor, and when it does that, it uses recombination, which means part of the DNA is cut out, which makes a circle called T cell receptor excision circle. Rest of it pastes to each other to form the final DNA that will make the receptor. So 70% of your alpha beta T cells make this circle called T cell receptor excision circle every time it makes this final baby T cell. So these TREX are a marker of T cell formation. If they are absent, then you want to look for flow cytometry to see if there are T cells or not. This newborn screening helps you determine if there is SCID, typical or leaky SCID, or Omen syndrome, or the T cells are absent because of some other reasons, such as syndromes, or secondary causes such as protein loss or third spacing. And then there are some patients who have idiopathic T cell lymphopenia. There's a long list of combined immunodeficiency syndromes. Can't go into all of those, but remember that there are lots that are not, they don't cause SCID, but can cause significant T cell defect, along with causing B cell functional impairment as well. Class 1 MHC defect is one of them. It's caused by, it gives rise to patients having recurrent sinopulmonary infections, can have granulomas, pyoderma gangrenosum, and vasculitis. Class 2 MHC defect, again, these are all bare lymphocyte syndromes, which means either class 1 or class 2 MHC is defective. These class 2 defect can present with respiratory and GI infections, as well as liver or biliary tract infections, disease. ICOS or ICOS ligand defects can present with recurrent infections. ZAP70 patients will have low CD8 versus normal CD4. LCK or ITK defects will have low CD4 counts and normal CD8 8 counts. We talked about DOC8 causing recurrent infections along with atopy and high IgE. DOC2 patients, we can present with recurrent herpes viral infections, some bacterial infections as well. Rho defect presents with HPV infections and warts. So again, this is just a short list, but there are several other combined immunodeficiencies, some of them syndromes. So let's look at few of those. Hyper IgM syndrome, we know that the T cells and B cells can be normal in number in these patients, but they cannot class switch, which means the T cells and B cells are not communicating well. Here the number of cells will be normal, but the communication between T cells and B cells, such as CD40 or CD40 ligand, is defective, because of which the B cells can make IgM, but for them to switch to GA or E, they don't get the T cell help. So the GAE immunoglobulins are low, response to vaccines can be low, and these patients can present with recurrent bacterial infections or opportunistic infections. These patients again may need immunoglobulin replacement and supportive treatment, but the more severe ones such as CD40 ligand, CD40 may need stem cell transplant. So CD40 ligand and CD40 defects cause this combined immunodeficiency hyper IgM syndrome. However, if the defect is in the class switching genes such as AID and those are just B cell defects, and that those look like B cell defects. Those patients will not have opportunistic infections. And then this is the list of other genes that cause hyper IgM syndrome. There are also some disorders like NEMO defect or PI3K, where the IgM is high, but they are not typically considered hyper IgM syndrome. There are other subtypes of combined immunodeficiencies. As mentioned here, those could be due to such as Wiskott-Aldrich, where there is thrombocytopenia. I think that's the next slide. Also, there are thymic defects such as 22q deletion. There are immunoosseous dysplasias like cartilage hair hypoplasia, and the list goes on. I'll mention the anhydrotic ectodermal dysplasia with immunodeficiency, or EDA, which is caused by NEMO defect. That's a complicated combined immunodeficiency as well. So the list goes on. Here's one more, Wiskott-Aldrich syndrome caused by defect in WASP gene. They present with the triad of eczematous rash, recurrent infections, and thrombocytopenia or small platelets. And treatment involves stem cell transplant and gene therapy is available. 22q deletion, here the defect is in third and fourth pharyngeal pouch formation. Defects leads to midline defects like heart defect or hypoparathyroidism and thymic hypoplasia. Less than 1% will have complete congenital athymia, which is treated by thymic implant or transplant. That's only done at Duke University at this point. Most of the patients do not have thymic aplasia, so they have some functioning thymus, there are some functioning T cells, and those patients need just supportive therapy. Hyper IgE syndrome, here there's a long list of genes that can cause that. STAT3 or Job syndrome is the typical one. They have these atypical facies, and along with that they are prone to having those cold abscesses. DOC8, again, not a hyper IgE syndrome by classification, but it does behave like that. High IgE, lots of viral infections or fungal infections. Comel-Netherton is caused by SPINK5 gene defect. That syndrome has bamboo hair. PGM3 can have neurological defects along with hyper IgE. So the list goes on. There are typical features of each one of these. Next one, a 2-year-old girl with perianal abscess that grew but cold area sepacia. Or what are we thinking of? For in benefit of just the time, I'm going to go ahead and give you this. We are talking about chronic granulomatous disease and neutrophils. Again, these patients will have poor wound healing and may have gingivitis, pneumonia, osteomyelitis, various granulomas. Patients can have leukocyte adhesion defect, where the adhesion molecules on their surface may be defective, because of which they cannot get to the site of infection, so they are trapped in circulation. These patients can have either of these types, LAD type 1, 2, or 3. LAD type 1 is the typical one we hear about, with delayed suppression of umbilical cord, no pus formation, but they have high neutrophil counts. LAD type 2 is less common, less common and also less severe form, and then LAD type 3 is also less severe form with bleeding problems. These patients may not need transplant, just like LAD1 would need. LAD1 would need stem cell transplant for survival. Chronic granulomatous disease, where the oxidative burst capacity is gone because of NADPH oxidase defect in any of these components of oxidase complex. Because of that, they can go ahead and phagocytose the microbe but cannot kill it, because of which these patients are prone to having infections with catalase positive organisms, as mentioned here. And we looked at the dihydrorhodamine test, and treatment involves stem cell transplant for curative therapy, but also triple prophylaxis can be used to reduce the severity and frequency of infections with interferon gamma, antibacterial and antifungal prophylaxis. Another case with fevers, headache, vomiting, and meningitis, you would be thinking of complement defect. As I mentioned, these patients can have sinopulmonary infections. Also, early complement defects can have autoimmunity, such as lupus, and late complement or terminal complement defects will present with your Neisseria infections or disseminated infections. 10-month-old with HSV and meningoencephalitis, these patients can, you want to think about TLR defects or defects in innate immunity. So there are multiple types of innate immune defects, like Mendelian susceptibility to mycobacterial disease, being predisposition to HPV, various viral infections, chronic mucocutaneous candidiasis, or invasive fungal infections. Think about TLR or pattern recognition receptor defects, which are pretty rare. Some of them can, such as TLR3 pathway defect, can present with very specific infections like HSV encephalitis. IRAK4 and MyD88 can present with pyogenic infections where there is no fever, no elevation of inflammatory inflammatory markers, but these patients can be pretty sick. And then here is a patient with hearing loss and lymphedema with atypical mycobacterial lymphadenopathy. This is a patient with NK cell defect. Some of these patients can present with recurrent severe disseminating viral infections like EBV and herpes infections. GATA2 can present with hearing problems and lymphedema. And then here, last one here, recurrent thrush, vaginal candidiasis, vitiligo, low calcium. We are thinking about APOSED. So again, defects of immune dysregulation, very long list of gene defects that can cause that. All right, so that was the last slide. I'll stop here. Any questions?